Hi, everyone. I'm going to give it a second for people to hop on, but welcome to NapNap's Facebook Live Peds Expert event. So welcome to NapNap Team Peds Expert Live, caring for the medical and mental health needs for youth in foster care. I am Dr. Tracy Hallis. I'm a pediatric nurse practitioner with my primary pediatric mental health specialist certification. Clinically, I practice at the Medical University of South Carolina in our foster care support clinic, and then I also serve as adjunct assistant professor with the Elmer School of Nursing at Old Dominion University. Within NAPNAP, I serve as the chair of the Child Maltreatment and Neglect SIG, as well as the co-chair for the NAPNAP Partners for Vulnerable Youth for the Alliance for Children in Foster Care. I'm excited to be here with you guys today. Our current NAPNAP president, Dr. Crawford, talked about, if you had the opportunity to hear him speak at our NAPNAP conference back in March, about the importance of caring for all children. And I think that's so important. But today and tonight, I'd really like to spend some time talking to you about a population in pediatrics that's near and dear to my heart, which is youth in foster care. May is Foster Care Awareness Month, if you didn't know that, and we're coming right off the heels of Child Abuse Awareness Month in April. And so there's no better time to really talk about this vulnerable population and what we can do as advanced practice providers to really kind of help and advocate for this vulnerable population. As I mentioned, my background is I currently work in a foster care clinic where I see youth in foster care providing primary care as well as behavioral health. Prior to that, I worked in child abuse pediatrics. So this is a population that I have cared for many, many years, and I'm excited to really just share with you some tips and tricks to really help care for their special needs. I know that many of you that have possibly at some point or time have encountered a youth in foster care, and it can be challenging caring for them. Many of you probably can relate to the challenges of having a child show up, whether it be in a primary care setting or an acute care setting, and really having limited past medical history, not having really any information at all, and kind of knowing how to best advocate and care for the kid. There are lots of challenges that we as pediatric focused advanced practice providers face, and that are all too common for all of us as we see in practice. But we want to really focus on today how we can best approach caring for these youth and best practices. There's a ton of information when you're caring for kids in foster care. As you can see, some of the highlights and statistics I'll talk about, but we're going to kind of narrow it down today and just kind of share some things that really can be helpful for you. So let's dive in. So I think we really can't talk about foster care with just really first talking about what is foster care. And most people probably already know this, but it's the temporary placement of a child outside of the home, away from really their family of origin. And it's typically because of some type of child maltreatment or neglect, but it can be for other reasons. And when we talk about foster care, a great resource for you if you're looking for kind of up-to-date statistics is really going to the Adoption and Foster Care Analysis and Reporting System, AFCARS. The most recent one is from FY 2022, and as of it, there are 368,530 infants, children, and adolescents in foster care within the 2022 calendar year. The average length of stay in foster care is around 22.5 months, and the average age in foster care is about 8.2 years of age. What we know about youth in foster care is, like I said, they're a vulnerable population, but they often have fragmented care. There's many racial disparities. A lot of the kids have medical complexities, and we have trauma histories. Providing comprehensive and trauma-informed care can be challenging for pediatric-focused healthcare providers, and so that's why we want to kind of go over some tips and tricks to kind of help. So, as I said, we know that it's a vulnerable population. They often have this fragmented and it's typically crisis-centered care. So whatever's going on at that time, either the kid, is an immediate crisis, maybe some behaviors are acting up, there's something going on that's maybe trauma-related. There's lots of things that are going on. So what do we know about youth in foster care? About 30 to 80% of youth in foster care have at least one healthcare problem. About a third have chronic health issues, and up to 80% of children in foster care have one or more mental health problems. That's pretty significant. About 40% have significant oral issues, so getting them to the dentist is really important. About 60% of youth in foster care less than 5 years of age have developmental delays, and about 2 times are more likely to have learning disabilities, and about 3 times more likely to have attention deficit hyperactivity disorder, and then PTSD, depression, and anxiety are experienced about 15% of the population. So pretty staggering statistics when we talk about this, and what really makes them, I think, a vulnerable population. And that's why the American Academy of Pediatrics, as well as the National Association of Pediatric Nurse Practitioners, has designated youth as in foster care as a vulnerable population. The American Academy of Pediatrics has guidelines for caring for this population. You can find them in Fostering Health, which is a great resource. And I'm really going to be highlighting those AAP guidelines today as we discuss some of the things that the NAPNAP Partners for Vulnerable Youth Alliance for Children in Foster Care have really put in place to develop some toolkits for you guys that should be coming out soon, that's really to help guide advanced practice providers in caring for this vulnerable population. So in doing this, I think there's really just some practical application and tips and tricks that can really help you kind of really knowing where to start with this population. As I said, like most of these are going to be based on the AAP guidelines, which a lot of the focus with their guidelines focus that it's a special needs, highlighting kind of all the chronic issues that we talked about, as well as just acute problems that kids can have in foster care. Really highlighting the need for physical and behavioral needs that they need, as well as increased surveillance. They need to be seen more often so that we can access them to care and get them the things that they need. Key components that we try to focus on in the toolkit really is number one, trauma-informed care, that increased surveillance, and then really like some tips and tricks, important things that we need to include in our documentation as well as in our plan of care. So along with Foster Care Awareness Month, it is Mental Health Awareness Month, and those are two of my passions that I really truly care about, and they really intersect a lot of time in my practice. And I feel like you really can't talk about foster care without talking about trauma-informed care. All healthcare providers should be using trauma-informed care, really relational care in all of our healthcare. Just like we should be caring for all kids, we should be using trauma-informed care in all aspects, whether it be primary care, acute setting, anything we're doing in healthcare. I think the important thing to remember as advanced practice providers really is that you're already seeing these kids. You're already seeing these, whether you know it or not, these youth in foster care, you're seeing in their practice. And hopefully you're already using those trauma-informed care principles, but going to look at how can we provide a little more specific guidance for this population. So really one of the things that I want to talk about is that trauma-informed care is really relational health care. And what we've seen is with the American Academy of Pediatrics and a lot of the literature and things that they're sharing is that there's a shift from really tallying those adverse childhood event experiences and really moving into relational care and building those relationships with these families. We're already doing that. And what we know is that higher ACE scores really equals poor outcomes, and that's really on a population level. But when we look at adverse child event scores, they don't really measure trauma. They don't tell us the form, the severity, their chronicity, or the frequency, nor the protective factors. They don't predict on an individual health level. And so really what we want to focus on is building those safe, stable, and nurturing environments. And we're doing that by screening and treating the trauma symptoms. So not necessarily looking at treating the score, but looking at those symptoms. So we're creating that safe environment that we're trying to do in our practices and in our hospitals. We're continuing to build trust and build those relationships. We want to empower our families and our kids and get to know them and what works well for them and their families, and promote a growth mindset. I had the opportunity at our annual NAPNAP conference with Dr. Bridget Van Graffelen to do a talk on trauma-informed care, really sharing some of the updates from the AAP guidelines. If you didn't get a chance to visit it, it should hopefully be available as a PCE, and I would encourage you to go and look at it. I'm just going to hit on some of the highlights. It's one of the things what I encourage you to take a look at. So really, some of the things that the AAP, Dr. Heather Forkey, Dr. Szilagyi, a lot of them shared as far as at the AAP, and what you'll find as far as if you go to their website with their new kind of national trauma center, there's really, when we look at trauma, we have what's called, there are three parts. There's the affiliate response. When we talk about like kind of when there's trauma, typically we have fight, flight, or freeze, and those ones that we hear a lot about, but there's also an affiliate response. And that really is kind of, there's a great video. We shared it in our conference. If you go look at the PCE once that's available, but a great website video that they have on the AAP website. Really it works and talks about really like as the brain, when you're presented with danger, you have that fight, flight, or freeze. But we're humans, we're not animals. And there's another stress response really that's called the affiliate response. And kind of the best thing that I like to describe this, if you think of, we talk about Mr. Rogers all the time and in crisis and when there's issues, he tells us to look for the helpers. And really this is what the affiliate response is. It's looking at those others around us, that connection. Think about if you've had a bad day. A lot of times you want to connect with someone, you want to talk, you want to share. You look to someone else to kind of help you kind of process or get through something that's challenging. Kids do the same thing. They look to adults and the people that are around them. They want to feel supported. And when you don't have that, in lots of cases, like for the youth that we see in foster care, when there's been some type of trauma, um, it kind of affects our brain. And we have that instead, that affiliate response, we have that fight or flight because we don't have that person. We don't sometimes have that protective caregiver. And so that as really as a provider with seeing kids in foster care is we want to kind of be identified as that person that can be helpful and protective for those kids. Someone that they can look to, as well as helping empower foster parents, guardian ad litems, case managers, families of origin if they're involved in the case, really helping them to be that protective person and teaching that. I think it's really important. The other piece that I kind of really want to talk about is the biobehavioral synchrony. And that's one of the things that they talked about at the AAP partner meeting that, and if you go to their website, they share. When individuals are interacting with each other, they align with their physiological response. Think about kids when they're looking at babies, they're looking at their moms. They look at their moms, that can help them. It's soothing and it's a positive relationship, can help bring that heart rate down and help release those hormone levels that they need to kind of the oxytocin that we need. And so that's something that's really important with when we're doing anticipatory guidance is that we're talking to these families about something simple as reading to our kids, spending some time making that eye contact, interacting with these kids to promote those healthy relationships. The other part is charting. So looking at kind of like when you look at trauma, the ABCs, we talked about the affiliate response, we talked about the biobehavioral synchrony. The other piece is the charting. And I use the example that Dr. Forkey kind of did when she shared this with the AAP partner meeting. It's really child and adolescents learn to understand themselves within the world. So our interactions with people, with caregivers or people, and it's kind of how the world is interpreted sometimes by that caregiver. And so when we look at like a map, if we only have one piece of the map, it really doesn't make sense. We need to see the buildings, we need to see the architecture, we need to see the other pieces in order to make sense of the relationship in other places. So I think these are really three things. Like I said, I'd encourage you to go see this, go look at the APP website. They have a lot of great resources and more information on this. So when we talk about really trauma-informed care and mental health, because that's one of the things that's really important as we talked about the staggering statistics of the kids in foster care having increased risk of mental health problems, it's really important that we incorporate that trauma-informed care. And really important to remember that we're seeing those kids because trauma can look like a lot of other mental health conditions. Trauma can look like ADHD, it can look like anxiety, it can look like depression. It can look like autism sometimes if you have really significant neglect. And so it's really important to remember this and consider trauma in your differential. And anything that you're doing, if you're treating something, if you have a mental health condition, and the kid's not getting better and you're using evidence-based treatments and the best kind of medicines and things aren't getting better, maybe go back and rethink that differential and think, could there be a trauma as a part of the problem? And has that been addressed? When we think about youth in foster care, the best evidence treatment is actually therapy. One of the best is trauma-focused cognitive behavioral therapy that can be really helpful for kids. And a lot of times kids can have trauma. They can also have other mental health conditions. But first, a lot of times we want to make sure that we treat that trauma. And we do that by using evidence-based therapies. There's really not really any medication indication for treatment for trauma in kids. The other piece that I really kind of want to talk to you about is really just that increased surveillance. And the AAP highlights some really good guidelines regarding this. And the biggest thing is that we need to be seeing these kids frequently and just in generally more often. We need to be seeing them. These aren't kids that we see like once a year and then we say, hey, see you back. And I'm going to talk a little bit about some of those reasons as to why we would see them, we would see them at different times. The first thing is we want to make sure that we're just doing a really good comprehensive assessment. It's so important. And a lot of times that's done in that first visit, but a lot of times what we recommend is doing it actually in a two-part visit. And there's a couple reasons why. In our clinic, and I think in a lot of other practices, we see them initially and then we see them back in a month. We do this because when kids are removed from their family of origin and placed in foster care. It's for a myriad of different reasons. But kids will tell you, if you talk to kids in foster care, sometimes being in foster care and even being removed and placed in a different home, it's kind of traumatic. No matter like how great the foster parent is, how great the case manager is, you're pulling them in from something that they know and moving them into something that they don't necessarily know. And so it allows time for them to adjust, to get a full picture, because sometimes kids are sometimes just kind of on their best behavior trying to figure out what's going on. And then we might see that there's some issues going on, or maybe there's not. It allows time to get records, because remember we talked about at the beginning that kids move placements a lot, and a lot of times we talked about that kid in the exam room where you had no information. It allows you to try and track down some records and get some past medical history. The other piece that I think from really a trauma-informed practice, it kind of minimizes invasive procedures all in one visit. So sometimes I think we empower kids on some practical tips as we decide kind of like, hey, do we want to do shots this time? Or are we going to do them next time? Are we going to do blood work this visit? Or are we going to do it next time so that we're not doing everything at once? And I think sometimes it just also like for some kids, a blood pressure is just, it sets them off. And my goal is not to traumatize them. So maybe I don't get that blood pressure that first visit, or I don't get that weight, but maybe I get it on that second weight. It allows time to build that relational care, build those relationships, get to know each other, and for the kid to build some trust and some rapport. The other piece of the healthy guidelines is really just trying to make sure that you're following kind of the guidelines. So remember I said seeing frequently. So the recommendations are actually from birth until 6 months that you're actually seeing those kids monthly. And then from 6 months to 24 months, you're following kind of the typical AAP guidelines for the ESPDT schedule. And then once you hit 2, the big difference for youth in foster care is that we're seeing them at least every 6 months. A lot of times they have those conditions, those chronic medical conditions, the mental health issues, so we're seeing them more often, and sometimes it's more 3 months. I would encourage you to reach out to your, look at what your state is. In the state of South Carolina, we get reimbursed for those well visits. And so I know that's not the same across the board. And something just to kind of hit on as far as foster care, there are general guidelines and some federal regulations with foster care, but it varies so different from each state. So I'll talk about a little bit later just about the importance of looking in your community and know what's in your state and know what the guidelines are for your reimbursement, what your guidelines are for when they have to be seen. Sometimes it's within 24 hours, sometimes it's within 72 hours, sometimes it's within 2 weeks. So really looking and seeing what your community and kind of what the recommendations are. The other piece is just kind of, again, like we talked about, you're already seeing these kids in practice. So you're doing all the things. So you're going to be doing a mental health screening, because the AAP recommends that we screen all kids as far as for mental health. But it's extremely important, as you can see, because like I think it was up to 80% of kids in foster care have mental health condition, at least one. So screening for mental health and doing it in a trauma-informed way. Screening for developmental screenings, like we talked about, their increased risk for developmental delays. And the importance of that is we know so often that early intervention is key and so important into best outcomes down the road. The earlier we get service in, the better we see those outcomes. The other piece is the medication assessment. One of the things that we talk a lot about for youth in foster care is so often the data shows that they're overprescribed psychotropic medications at much higher rates than kids not in foster care. And so often, sometimes because they move placements, they have a different foster parent, they're seeing a different foster parent. This person's adding this medicine, this person discontinued this medicine, but guess what? There's not good communication sometimes, and so kids stay on lots of medications. So often they're on multiple medications for the same reason, or maybe something they shouldn't be on at all, because really we should be addressing the trauma. Again, kids can have mental health conditions and need medications, but we just want to be responsible. We want to be reviewing those things to make sure that they're on what they're supposed to be and that there's good stewardship with our medication use in this population. Other considerations really is care coordination. Like we talked about, those kids, they move placements off often. There's so many hands in the pot. You have case managers, guardian ad litems, all those people that can be involved. And that's one of the things that you'll see when the toolkit comes out, there's a great dictionary of words and acronyms that are used in and for kids that are typically seen for child maltreatment and neglect, which is really helpful. Guardian ad litems are people that sometimes are representatives from this court that really advocate for that family, and their case manager is usually who's with Child Protective Services. But even in that, like your state, it could be called, ours is called Department of Social Services. I think in Georgia it's DFAC. There's lots of different things, so look at what's in your state. The other part is legal implications. So again, looking at your state guidelines, knowing your also your organization. Different hospitals and organizations have different stipulations for consent, other pieces. So know what's kind of in your area. The other piece is being culturally sensitive, especially I think, and talking to your families about it, realizing that this kid is being removed from their family of origin. They're being placed with another family that might not have the same beliefs. And so I think being really sensitive to that and talking to families with that and being an understanding, some are more than others, I think, understanding, but I recognizing it and recognize that there's differences in placements, and that can be a challenge. The other piece that I really kind of want to talk about that we tried to highlight in the toolkit, and I think it's just so important when caring for kids in foster care, is really just our documentation. What kind of information are we gathering and why are we gathering it? One is just through a continuity of records. Like we talked about, those kids, they moved often. There's lots of agencies involved. And so making sure we're sharing the information, but we're doing it in a thoughtful way so that people understand it. And in medicine, we use lots of fancy words. And so making sure it's in a way that people can understand it and not all this medical jargon. Some important things to include is the type of placement. There's different type of placements in foster care. One is kinship care you'll hear, which is being placed with like family or family friend or relative. The other one is a foster home, which usually it's a caregiver that's licensed through an agency. And then the other is congregate or group home placement, where it can be a group home. And there's different levels of group homes. I'm not going to get into that because that's kind of getting into the weeds, but just being thoughtful of knowing what type of placement there are. When you look at the hierarchy of placement, kinship care is typically the first type of placement, and that what Child Protective Services would like to get kids in. Then you move to a foster home and congregate. And congregate just can be challenging, I think, just because it's lots of people living in one place, lots of people being triggered by lots of different trauma triggers and other pieces that can be challenging. The number of placements is also important to include in your documentation. And the reason is because typically the more placements, sometimes typically we have more challenges. The more we've moved around and we bounce, could it be because of behavioral issues? What's going on as to what's causing that is just kind of important. The other thing is permanency planning. This is really important. So if the plan is to be reunited, like can we get that family of origin in? Can we involve them in the medical planning? If the plan is for termination of parental rights, meaning the parents lose all rights to the kids, should we not be including them? Are they going to be adopting? Can we have that adoptive parent that might be coming in so that we, or caregiver in, so that we can kind of help plan in the medical planning, especially for our youth that have really a lot of medical complexities. This is really important. Visits, whether it be with siblings or the family of origin, is also really important. I think if you're managing, just as we know, a lot of times kids in foster care can have behavioral challenges. If we're managing behaviors, it's kind of important to know if they're having visitations, because a lot of times you'll see an uptick in those behavior challenges after they've had visitations. So it's kind of important to know. Are they in trauma treatment? It's really important to know, especially if you're managing behaviors. Where are they in their trauma treatment? If you ever know anything about trauma-focused cognitive behavioral therapy, which I'm not going to go into it, but part of it is writing at the end the narrative. So they build all these coping skills, they work through things, and they're writing that narrative, and they're talking about what happened to them. And so sometimes when they're kind of going through that, that can be kind of triggering for them. And so are we seeing an uptick in behaviors or trauma symptoms? That's important to know. The other thing is transition planning, and this is there's within foster care, there's a couple of vulnerable populations in and of itself, and so that's youth aging out of foster care. That's a special population, and so really we should be doing transition planning from age 12 or 13. Something as simple as I like to talk to people about is making sure when they're old enough that they have access to their portal so they can access the records as they move out of Child Protective Services. Know when they age out of care, because that can vary from state to state. In South Carolina, you age out at 21. At other states, it's 18. And then simple things like how to make appointment. Like sometimes I have them walk out and not have the caregiver go with them. Have them go out and make the appointment. So them learning to do those things. Do they have a license? How are they going to get around? How are they for transportation? Are they use public transportation, housing? Those kind of pieces are really important to talk about. The other part is case management communication, which I've hit on. Like I said, there's so many hands in the pot, but it's really important, especially like I said, with those kids with medical complexity, that we're sharing the information so that things aren't falling through the cracks. A couple last things that I want to talk to you about is just really advocacy. We are in a unique role, and we are good at advocating as advanced practice providers, advocating for youth in foster care, but just kids in general, all kids. And so I really want to empower you to realize that they're a vulnerable population and that our job is to kind of help them have a voice, and do it in a trauma-informed and building those relationships. One of the things that I think is so important is just get involved in your community. We have the opportunity, we have the Child Maltreatment Neglect SIG. We are always welcoming new members. The National Partners for Vulnerable Youth Alliance for Children in Foster Care. We're also looking for volunteers for lots of our initiatives, as well as within the Partners for Vulnerable Youth, all the alliances that kind of intersect a little bit, but the Alliance for Child Trafficking, great way to get involved, as well as the Alliance for Suicide Prevention, another great place. And then I always talk about when I have students with me or doing any type of lectures, is I always talk about it's really about connection, relational care. And us as providers, it's really important that we make friends in our community. We know our child protective service agencies. We know our guardian ad litems. We know who our trauma treatment providers are. We know who in our community is really good at seeing kids in foster care. And we maybe ask them to mentor us or tell us their tips and tricks in our community. And then within our psychiatry, because we have a high behavioral mental health, knowing what's in your community, making friends with psychiatrists, accessing psychiatry support programs that might have in your state. It's just really important, I think, is also as providers, is that we take care of ourselves, because listening to this trauma, hearing the awful things that some of these youth have gone through can be really hard. And so helping to kind of build the community and help prevent against that vicarious trauma, I think, is really important. This is all kind of I have. I'll look to see if we have any questions, and then I'll be sure to share references, as well as I have a bunch of resources that I'd love to share with you guys. I feel like I talk really fast, I know, but tried to share some information, and I can see that they dropped some of the AAP resources as well as partners. Even if afterwards, with the end of this Facebook Live, if you have any questions, please reach out. You can reach me. It's my last name, Hallis, at musc.edu. I'm always happy to chat. I'm happy to be your friend and make a connection for people that are seeing youth in foster care. I think that's so important. And then go check out both the AAP as well as our NAPNAP Partners for Vulnerable Youth. And then hopefully soon we'll have that toolkit that's available to you guys so that you can access and kind of be good advocates for youth in foster care. I'll wait for just a few minutes to see if we have any other questions. Thanks, Stacy. Well, if we don't have any questions, like I said, feel free to drop me questions, shoot me a message. I'd love to connect, and I could talk about this all day long. I tried to hit some of the highlights and tips. It's been a pleasure, sharing again two of my passions, really three, I guess, if you put it: foster care, trauma-informed care, and really mental health. Our kids really need us, and we can be advocates and experts in caring for all kids, but especially kids in foster care. Thanks so much, guys.